Hello, everyone. Thank you for joining us today. We're just about a minute from the top of the hour and we'll get started. I'm going to allow a couple seconds for everybody to join us from the lobby. All right, we are right at the top of the hour, so welcome everyone to the Rural Health Executive Webinar Series. I am Kodi Smith, your Partnership Manager with NRHA Service Corporation, and I'll be your moderator for today's presentation. Before we dive in, please note that there will be a short survey at the end of this webinar. Your feedback is invaluable in helping us to refine and tailor our future webinars to best serve your needs. To maintain a distraction-free webinar, all participants will remain mute throughout the session to avoid any background noise. However, we do value your active participation and encourage you to ask any questions you may have during the webinar by entering them into the go-to control panel, along with the name of the panelist you wish to address. Our team will collect and address all the questions during the discussion at the end of the presentation. I'd also like to remind you that this event is being recorded and you will receive an email to the link of the recording later today or tomorrow morning. All right, so today's webinar, Bridging the Gap, Leveraging Telehealth to Drive Value-Based Care in Rural Hospital Settings, is brought to us by our dedicated partners, Equum Medical and Stroudwater. Before we begin, I would like to extend our sincere thanks to our dedicated partners. We are grateful for their continued support and industry expertise, which allows us to host conferences, educational webinars, and other events dedicated to improving rural healthcare. Their support is critical to our mission of advancing rural healthcare initiatives. And not only do our partners share their knowledge and expertise, but they also play a significant role in supporting NRHA's efforts on Capitol Hill. Their advocacy and support are essential to our ability to influence policy and secure funding for rural healthcare programs. So once again, we thank both our partners, Equum Medical and Stroudwater, for their ongoing support, and we are so honored to have you as our partners in our mission to improve rural healthcare. So I'd now like to introduce our esteemed panelists who will be guiding us through today's presentation. We are joined by Eric Schell, Chairman at Stroudwater. With 30 years in healthcare financial management, he's been pivotal in transitioning rural healthcare to population health, assisting rural and community hospitals, clinics, and physician groups in improving financial and operational efficiency. And he's played a key role in creating national performance programs. Eric is an active member of the National Rural Health Association's Rural Health Congress and has held roles within NRHA's Governmental Affairs Committee and the Federal Office of Rural Health Policy. Next, we're joined by Dr. Kodi Scurlock, CEO of Equum Medical, an intensive care specialist with roots at New York Medical College. Dr. Scurlock has overseen Equum's expansion across 15 states. With a rich academic background, including Harvard Medical School and an MBA from Cornell, he boasts over 70 peer-reviewed publications. So without further ado, I will now turn this over to Kodi for our feature presentation.
Next slide, please, Kodi. Thank you, Kodi, and Eric, it's a real honor to be up here with you. I think just in terms of our agenda and objectives, this is really setting the stage for the presentation. Obviously, Eric's going to give you all a very nice talk on value-based care, particularly as it relates to the rural hospital environment. And then he'll turn over to me and I'll talk a little bit about telehealth, the history of telehealth, some literature around telehealth, and then we'll share some success stories, and then we'll close and hopefully take some questions. So Eric, I'll now turn it over to you. Thank you.
Thanks, Kodi. Next slide. And next slide. So anytime there's a presentation that has anything to do with bridging the gap, you know you're going to hear from me, and you know you're going to hear about the shaky bridge. And so, you know, in about 15 minutes, we're going to get out why I think telehealth plays a role in this bridging this shaky bridge, this gap between, you know, the payment systems of the past and the payment systems of the future, and then set Kodi up to talk about how specifically telehealth will do that. So, kind of this goes back to a lot of presentations that many of you have heard me talk about in the past. The driving forces behind why we're seeing this payment world shift from this world of fee for service, right, fee for sick care, to a world where payment is tied more to a population. And I look at this, and essentially there's a number of key elements that are driving this. The first is this continued cost escalation, and as cost goes up, and right now, actually last year, the cost of healthcare insurance for a family of 4 was $22,500, having gone up from $5,900 20 years ago. This cost escalation, what it has done, really, anytime you see prices go up, economic forces say, generally what happens is demand for a product goes down and supply increases. Now, demand, on the demand side, to some degree, the government stepped in, but on the supply side, I am going to turn off my webcam just because I'm getting a notice that my internet might not be stable, so I'm going to do that for a second. But on the supply side, coupled with this incredible technology revolution that we've been experiencing for the last 50 years, we've got new substitute players coming into the industry, and these involve the folks like Walgreens and Walmart and CVS, Aetna, and Amazon. All of these folks, these new market technology-based companies, are coming in saying, "Thank you very much, but we think we can do this better, and we can make a buck by doing that." So the result that we're seeing is we're seeing declining volumes. And again, if we live in this payment world of fee for sick care, and we're seeing volumes starting to come out. I just gave a presentation outside of Sacramento on Monday at a board retreat, looking at California emergency room visits. They've been on decline since 2015, where in 2015, there were 350 emergency room visits per 1,000. They're down to 290, I believe, for 2021. And so with declining volume in a fee-for-service environment, we're going to be forced to be doing something else. So our rural hospitals are paying of CARES Act. And frankly, there's an entire push to value-based payment. Somewhat is driven by these new market entrants, that have literally in the last 2 years have spent nearly $40 billion primarily investing in primary care. They've put a bet. The only way they're going to get a return on investment in primary care is if the payment system is evolving to this population-based payment. So we've got the market setting this up. We've got the government saying we want 100% of Medicare beneficiaries in either Medicare Advantage or an alternative payment model by 2030. We've got this entire movement to turn upside down payment. Thus, a couple of the bullets here: fee-for-service is not a risk-free payment. As costs increase, as volumes come down, and we're living in this large fixed cost infrastructure of traditional healthcare systems, the fee-for-service payment system's ultimately not going to work. The fact that fee-for-service, fee-for-sick care discourages funding in health, and then ultimately we have the greatest ability at the current state to affect quality and cost. That with the incentive to do so, I think we could make a significant indent there. So all of these things are meant to say that the payment system's evolving. Why is payment so important? Next slide, Cody. Is this slide right here? This if you believe in this premise that form follows function follows payment, right? And if you think about that, we live in this fee-for-sick care environment, predominantly fee-for-sick care. Functional imperatives of that payment system are maximizing one's price, maximizing one's volume, sick care volume, and minimizing one's expenses. Those three functions, one healthcare or sick care organization can do independently. So the form that evolved out of that was independent organizations competing with other for market share, right, for volume. We're moving to a form of population-based payment for all the things that we just talked about. If you think about the functional imperatives of a population-based payment system, no longer, it's aggregating lives to diversify insurance risk. It's about, creating a horizontal network of both healthcare and sick care, everywhere from hospitals, tertiary care, primary care, specialists, post-acute care, public health, diet. All of these things are going to be pieces of a population-based payment. It's an aggregating form of payment. And so, again, if payment's evolving, if form follows function follows payment, right? As payment evolves, our function and what we do and how we look doing that is going to be changing. Again, I'm building up the case for why I think telehealth has a role in this world. Next slide, Kodi. And so, okay, if payment is going to evolve, what's it going to look like? And several years back, Dr. Raj Kumar, who was the deputy director of Centers for Medicare and Medicaid Innovation, came up with this payment system. Let's just call it an evolution, not a revolution, an evolution. And he looked at, kind of the first phase of payment in this category 1 on the left, fee for service with no links to quality and value. For the most part, this doesn't exist anymore. So where are most of us now? I believe most of us are in this category 2, which is fee for service, but now links to quality and value. We get incentives for quality. We get some fee for service payment for investing in healthcare. And then, through MIPS and other value-based payment programs, it's primarily fee for service, but links to quality and value. Most of us are there now. Category 3 of payment, alternative payment models built on a fee-for-service architecture. This is the ACOs, low risk things, and I'm going to talk about why I think this is the most danger of all to be. And then finally, population-based payment built on a population-based infrastructure. And again, that I believe is a much more stable, although challenging to get there. So this is that evolution of payment over the next several years. That is being predicted. Next slide, please. There it is, just in case you hadn't seen the shaky bridge in the last 3 months. This slide, once I say 1,000 words, is worth 1,000 words, this picture. And but there's a lot to be, this terrible graphic says a whole lot, and it explains a little bit of the challenge we are right now. Think of this as the payment system as it evolves. If you look on the far left, fee for service, going back a slide to Dr. Raj Kumar's payment evolution, this is that fee for service with no links to quality and utilization, right? This is straight fee for service. I would suggest to you that is smoldering and not a safe place to be anymore. And the reason why I say that is volume fundamentally coming out of the system through attacks from new market substitutes, changes in service provision, new pharmaceuticals reducing need for hospital services, right? So in this payment world, it's price times volume is net revenue. You got volume starting to come out. On the payment side, you've got the Medicare, the largest payer, updating price at a fraction of what cost is going. So price relative to cost is going down. All of a sudden, this pillar that once was such a great thing and we all loved it, and it's the reason why I believe is one of the biggest reasons why our costs are where they are, is smoldering. So if you go way over to the right, this is Dr. Raj Kumar's 4th pillar of payment. Perfectly aligned payment delivery system. This is one in which the less sick care we do, the more healthcare we do, the better we off financially. But everything in between is schizophrenia. If you look, I would put Dr. Raj Kumar's 2nd pillar, right? Fee for service with tie-ins to quality and utilization, kind of right where just to the right of the blue stable pillar, but still in a position where you could jump back if you have to. If you go forward, it's going to get tough, and then it comes out. But I believe where we are as an industry now is kind of right to the right of the blue pillar, with feet safely above the crocodiles. The 3rd pillar, I believe, is right where his foot is above the crocodile. And the reason is everything that we do to create health, when we're still measuring financial performance and cash flow based on claims, sick care utilization, this is a scary place to be. And it doesn't get better until we step aside to the right and start to step away from the crocodiles. The challenge that we have, though, is you just can't step from the blue pillar to the green pillar. And the reason is because we fundamentally don't have a healthcare system. It's going to take years to create. We have a sick care system. And so it's going to take us time to develop the infrastructure to be effective as traditional sick care providers in actually creating true community health. And so the question I have is your feet are just to the right of the blue bar. You've got a position to make, or you've got a decision to make. Do you go forward or are you to go back? Knowing if you go forward, it's going to get more difficult before it starts to get better again. And thus, that's, I believe, the entire industry is stuck right where, just to the right of that blue pillar, because going forward is going to be tough. So next slide, please. So several years ago, we created this we call it the transition framework. I know many of you have heard me talk about it, although I've only had about 3 people get it on the first try. And let me explain this, because this sets up the conversation of where I think telehealth fits into this, this bridging the gap. So years ago, a physician at the Georgia Hospital Association, he talked about, Eric talks about this shaky bridge. He said this transition is the concrete path across the shaky bridge, was his interpretation of this. And so let me explain it to you. So going across the top, you see the x-axis where it says fee for service, and then at phase 1, phase 2, phase 3, and then provider-based plans. What this is this is the payment system over time as it evolves. And we talked about the fact that as the payment evolves, form and function have to evolve, because what we do is going to change, and how we look in doing that has to change. So I look at phase 1 as where most of us are right now as an industry, fee for service with tie-ins to quality and utilization. It's that second pillar of payment that Dr. Raj Kumar presented. Phase 2, this is the feet right above the crocodiles. This is alternative payment models built on a fee-for-service architecture. Phase 3 is where your feet start to lift above the crocodiles now, and we're getting to population-based payment on a population-based infrastructure. And then finally, what we believe is the end goal is where provider-based organizations link to insurance companies and have this residual claim on health, to the extent the organizations like physicians and hospitals integrate to create healthcare, to take out sick care, and have a financial benefit for doing so, is the end of this spear. So how are we going to do that? Well, there's 7 initiatives. Each one of the initiatives, it's a row, and each one of the initiatives has a strike point. The strike point is where it hits the orange bar, coming down from the top, coming up from the bottom, and then there's orange markings around each of the bars in the blue bar in the middle. Okay, so there's 7 initiatives. The first 3 are how we transform our sick care model, because we just can't stay the way we are in sick care. We have to transform it. The second bar is population health. We have to create a healthcare system by fundamentally investing in the health of our communities. But we have to be very careful, because we don't want to go too fast, because we're still getting paid, where I've circled column 1, we're still getting paid for healthcare, or excuse me, for sick care. And if we create health too quickly, then we're in trouble. So think of the blue bar in the middle as a crawl and walk in column 1, a walk in column 2, a run in column 3, and a sprint when we get out to the end. And then coming up from the bottom, we have to fundamentally pick up and pay for or proactively move the payment system. And that starts at the bottom. And so some of the initiatives, initiative 1 coming down from the top, and because it's hit the orange bar, it's a strike point. We have to do it now. And so what is it? Operating efficiencies. We have to improve our operating efficiencies. We have to improve our quality. We have to be able to compete on quality, and we have to engage our patients. And when I mean engage our patients, I'm becoming stronger and stronger attached to the philosophy that our #1 opportunity around getting people into our hospital now, is to engage them on the healthcare front. And so patient engagement, absolutely critical. Primary care alignment is the second initiative down, because as we move out to column 2 of payment, your primary care physicians with patient attribution will be your revenue centers. And then finally, the third one down is service area rationalization, coming together in larger systems to take out big chunks of fixed costs. The strike point for that is in phase 3. If you look at the blue bar in the middle, today I'm just going to focus on that. Patient-centered medical home or like model, care management, data analytics, evidence-based protocols, building the infrastructure for proactive outreach to patients, and more managing from a population health perspective. Coming up from the bottom, today, if you have a self-funded health plan, what have we done around creating, plan design to encourage healthy behavior, discourage sick behavior? What are we doing to maximize all of the fee-for-service and quality and utilization opportunities, chronic care management, et cetera? Coming up from the top, transitional payment models. This is implementing your low-risk ACOs. Today we plan in column 1 to strike in column 2. And then last is your full risk cap plans. And the strike point for that isn't out until payment 3. But in the end, when you have the first 3 rows of transformed sick care coming together with the bottom 3 rows of proactively advanced payment with healthcare in the middle, we have these large provider-based health plans that have integrated insurance and sick care and healthcare functions in them. All right, last slide, and I'm going to turn it over to Corey. Where does telehealth fit in this? I look at, and I've circled the 2, kind of initiatives where I think telehealth has the biggest play. The first is and again, it's a strike point today. It's improving operating efficiencies, quality, and patient engagement. Using telehealth to keep patients local in our hospital. Every patient that we can admit, and a paying patient, improves the efficiency of our hospital because we're diluting our large fixed costs. 85% of our costs are fixed or step-based. Any incremental patient that we can keep in our hospital, whether that be inpatient or outpatient related, we diluted our fixed costs. We became more efficient. We're able to engage more patients, especially on the outpatient side, but also on the inpatient. To the extent that we can keep them in our hospital, it's a form of patient engagement. And to the extent that we can drive quality with providing services in excess of community expectations through telehealth, it's a win for every single one of those first 3. If we jump down, service area rationalization. So again, MBA talk, but coming together in larger systems to take out big chunks of fixed costs. I look at it and say, if you have to employ an entire group of hospitalists or intensivists or something to keep patients local, that's a big chunk of fixed costs that you can make the decision whether you make or buy. If you can buy it off of a service, then you can take out a big chunk of having to staff your inpatient unit or having specialists in your hospital, in an outpatient setting. You can take that big chunk and then essentially buy it at a much lower cost. So I think telehealth has a significant role in bridging this gap on, this payment transition. So said a whole lot there. I'm going to turn it over to Dr. Scurlock right now and let him take it home.
Thank you, Eric. And next slide, please, Kodi. So I'm going to talk a little bit about telehealth. I'm going to start at a super micro level, and I'll scroll into my personal history, and then I'll broaden out into the whole story of telehealth, particularly as it relates to acute care medicine, and particularly as it relates to rural hospitals. So, I myself am the product of a rural environment. I grew up in a town, not a city, called Gladewater, Texas, which is in the northeastern corner of Texas, about 2 hours from Dallas, an hour and a half from Shreveport. When I was a teenager in that town, the local hospital closed. And if you really needed care, you either were driving to Dallas or, as I mentioned, driving to Shreveport. And that just didn't feel right to me. So as I went to college and then to med school and residency and fellowship, I sort of wanted to make an impact with my career and pay back the people of that rural environment and find ways they could have access to specialists. that really led me into telemedicine in 2011 and then founding Equum. And Equum, is a short for the Latin word for equality. But what we mean by is equality, we want equality regardless of geography. Next slide. So, obviously I got to now talk about Texas since I brought it up, but I think we can learn a lot from Texas. Texas as a state has 82 critical access hospitals. They lose about 1 rural hospital per quarter, so our 16 over the past 4 years. And while rural hospitals provide care to only about 15% of the state's population, due to disparate geographies, about 85% of the state's geography is actually covered by a rural hospital. Now, a third of Texas counties do not have a hospital at this time, and so they're very dependent on these widely dispersed hospitals. And sometimes, to get care, patients have to drive over 70 miles to get to the nearest hospital. Maybe the most important part of this is that rural hospitals aren't just the health driver of their community, they're actually also an economic driver. And so when a rural hospital closes, not only does it prevent access for patients and prevent patients from seeing specialists, it also drives the economy of the town or city or area and can really lead to unemployment. And so, next slide, please. And so these problems aren't just peculiar to Texas, they're actually nationwide, they're in every state in the union. And so, telehealth to me can be a panacea for helping to solve these problems. And so the problems that rural hospitals face is, number one, how do they increase access to care 24/7, regardless of geographic barriers? Number two, hospitals need to address what services are there so that patients don't inappropriately transfer out of their community, leak out of the system, and lose brand awareness. And then number three, in what ways can we make our local care providers feel supported by telehealth and prevent their burnout, prevent them leaving the community? And so the rest of the talk will focus on this, and also I will focus on patient flow. So next slide. Next slide, please. A little bit about the history of telehealth, and give me a minute to set this slide up. On the x-axis, there's time, and for the purpose of this, time starts in March of 2020 when the COVID pandemic started. On the y-axis is demand for telehealth. And so let's start with that light blue line. And with that light blue line, you see that was the early phase of COVID nationwide, in which patients couldn't go to clinics, doctors' clinics were closed, and there was a surge in the usage of outpatient telemedicine. Now, as patients became sicker, we get into that red line. As they started hitting the ER, started hitting the hospital, you had the surge of inpatient demand for telehealth, and that has surged. But maybe the most important part of that graph, and this whole slide tries to predict where we are now, and this article was written in 2020, is from the time the x-axis starts until the beginning of that green line was a really important period. And in that period, preventative care wasn't being done, elective surgeries were not being performed, screenings were not being performed, and we accumulated what we call a care debt. Now that care debt has to be repaid, and that represents that growing green line, which is where we are now, is at the peak of that green line. And unfortunately, that peak is at a time where there are staffing shortages. And so we're now faced with very high acuity patients with not enough staff. And telehealth really now will find its true meaning in health moving forward. Next slide, please. A little bit about the history of telehealth, and really telehealth is in 4 distinct phases. So if we think about pre-COVID, telehealth was actually growing at about a 300% annual rate. It just wasn't, people just weren't as aware of it as they became during COVID. Now, during COVID, you had this period, what we call panic buying, in which telehealth grew at a 2,000% annual rate. Now, in this period of panicked buying, hospitals were facing the pandemic and they faced real crises. And so they bought disparate, disconnected products. So a good example of that is, hey, I have an ICU problem, I'm going to buy a tele-ICU solution. Hey, I have a hospitalist problem, I'll buy a hospitalist solution, a telehospitalist solution. Now, often these were niche products, they're disconnected. And as we came out of the pandemic, we're now in the center there with the emerging state. Now, during this period of the emerging state, which is where we are now, hospitals are looking at these products they bought in telehealth and saying, am I getting return on investment for this product? Am I getting out of it what I need? They're also looking for their vendors to start talking to each other. They don't want a telehospitalist solution that does one thing and a tele-ICU solution that does the other. They often are competitors and sometimes don't speak to each other. What they're really looking for is integration into their EMR, integration into their culture, integration into their workflow. And that leads me to where we'll go, which is really the future state. In the future state, there'll be less and less telehealth vendors, and hospitals will look for a multi-service vendor of choice, one that is really like a platform for them. And what I mean by a platform is they're able to scale, they're able to be flexible, they're able to be innovative with the hospital system, much like an EMR, and they can go from admission to discharge. But I'm not talking about a technology platform, I'm talking about a people platform. And that's really important. And so, the hospital's ability to innovate should not be limited by staffing. And I think that's where hospitals will move as they further and further integrate virtual care. Next slide, please. So telehealth, and if you're doing a telehealth presentation, you obviously have to show technology, but that's really the minor part of it. So telehealth in its simplest form, the definition of it is using audio and video technology to connect patients and providers. It comes in lots of shapes and sizes. It can either be centralized or decentralized. There can be central hubs like pictured to the right, or you can have distributed doctors and nurses across the country helping to take care of patients. If you move to the left, there's some of the examples of hardware that's typically in the room. You have things from all the way from pan, tilt, zoom cameras down to monitors and eventually iPads. Now, what's really important in telehealth, everybody gets focused, they get focused on the technology, but the technology should be a secondary decision. What's more important is you figure out the use case of what are you trying to do with telehealth, and then you build your technology into it. And when telehealth programs fail, they never fail because the technology didn't work. That's very rare. What they typically fail, they fail because the clinicians on both sides of the camera or both sides of the technology didn't understand what KPIs they both were chasing. They didn't have good lines of communication. They didn't have regular meetings so they could evaluate workflow. That's really the important part of telehealth. The technology has to work, but what's more important about it are the people and the process. So next slide. I want to introduce this concept of patient flow, and this is a good example. And so how does inpatient telehealth help rural hospitals in particular? And so the key around this is patient flow. And so what do I mean by patient flow? So number one, we want to get the right patient, the right care at the right place at the right time. Number two, we want to work in the ER to make sure we don't have inappropriate transfers or that we don't have delays in care. And then when the patients get admitted, we want to shorten their lengths of stay and then move their discharge times into the morning so we get net capacity through hospitals. So flow as a concept is really about moving the patient through the system appropriately and safely. And so if you start in the ED, as I mentioned before, that's often where the decisions are made around triaging and transfer. And so having access to a specialist, whether they're a critical care specialist, a cardiologist, an infectious disease doctor, having access to that specialist can, one, prevent leakage and help you allow to keep patients there. Once the decision has been made to admit the patient, either what your hospitalist or your critical care team, and those can be tele as well, helping to pull the patient into the hospital as rapidly as possible with a tele-nurse, pull them out of the ER so they don't have delays in their care. Then once they're admitted, you want to shorten and compress their length of stay so it reduces their complication rate. And then into the med-surg area where you have things like virtual nursing to move discharge times from the evening into the morning so that patients can move out of the hospital faster, or things like virtual sitting, which replaces the typical one-to-one with a camera and limits falls, but also has great effects on variable cost and safety. And maybe most importantly, returns care back to the nurse, returns staff back to the bedside nurse so they can really focus on nursing and not focus on watching patients. Next slide, please. So factors driving telehealth, obviously now the adoption curve's been shifted with COVID and everybody's very, very aware of telehealth. But in rural hospitals, the #1 driver of telehealth adoption, number 1 through 10 really, is staff shortage. Now for 25 years, we've known we've been short for psychiatrists, neurologists, and critical care physicians. And in fact, we are now on the 25th anniversary of the first tele-ICU, which was in 1998. But now we're also experiencing other types of shortages like hospitalists, specialists like particularly cardiologists, nephrologists, infectious disease doctors, and maybe more importantly, we now have a shortage of nurses that isn't going to stop anytime soon. That shortage is been driven by burnout and COVID, but also it's driven by baby boomer retirement. And as baby boomer nurses retire, not only do they leave the workforce, but they become patients more often than not. So it's a double hit. So number 1 through 10 is staff shortages. I think that the next biggest cause is demand for nighttime and weekend care, particularly of the high acuity patients, those patients who are repaying their care debt. As those patients hit the hospital, you need higher levels of specialists because the acuity is higher. And then every hospital is focusing on clinical quality and patient safety. We know with certain diseases like sepsis, stroke, STEMI, that time is not your friend. Time is tissue. And we really want to accelerate the time to treatment. And many times the only way you can do that is through telehealth. And then importantly financially, but also important for patient care, reducing inappropriate transfers, enabling patients to stay closer to their home and stay in their rural hospitals. Next slide.
Hey, Corey, just real quick, I just want to say that, what you just talked about on that slide was that first row in that transition framework around improving the operational efficiencies, whether it means, better opportunity to nurse staff, keeping patients local, which drives down, fixed costs over higher units of service. Those 8 or 9 things that you just talked about fit right into that first row of the transition framework. So thanks for putting that together.
Yeah, absolutely. And telehealth and what you discussed are so synergistic that there's going to be a lot of natural synergies between what we talk about, and I hope there's more and more parallels. So feel free to point those out. Moving now into the literature around telehealth, particularly as it relates to rural hospitals. I took this study. This is an ER study or emergency department study, and it looked at a concept called tele-ED, which is really using tele-emergency physicians in the ER to help triage patients appropriately. And so they compared 14 hospitals in Mississippi with 102 rural hospitals in Arkansas, Georgia, and South Carolina. And these were all critical access hospitals. They were all of similar size and model. And what they found, and those are the graphs to the right, one's adjusted and the other one's unadjusted, and the bottom one's probably the easiest to look at, is they found that the tele-emergency ER costs were about 31% lower than hospitals that didn't have tele-emergency. But the other thing they found is in the 14 hospitals that did have tele-emergency, 0 of them closed. Whereas 18 of the 102 hospitals closed who did not have tele-emergency. So there seemed to be a protective financial effect from having tele-ER. And so getting involved in the ER, critically important in reducing costs, but also in preventing unnecessary transfers. So next slide. This is a great study. This is one of the classic tele-ICU studies, and it really looks at layering a tele-ICU and creating a tele-ICU in a rural environment. It was in UMass, and then adding into it what's called a logistics center, which really helped change patient flow. It was like air traffic control for patients. And then beyond that, layering on a care standardization arm or the fully functional logistics center. So if you look at that graph at the top, which is really at the x-axis, which is time, what you see is there's 3 distinct graphs. There's case volume, which as you added the tele-ICU, case volume went up because less patients were being transferred out. And then revenue is that green line. So revenue per case kept going up, 1, because higher acuity patients were in the ICU, and number 2, because of better documentation. And then when you look at the cost per case, while the initial cost per case, which is represented by that red line, while the initial cost per case went up, that was in building the tele-ICU and building the infrastructure around the tele-ICU, it eventually went down. And that was really due to the care standardizations there. And so if you looked at the 10-year effect of this, it improved contribution margin by about 600%. And there was about a $50 million advantage to the system that used this. So higher patient volumes, higher revenue per case, lower cost per case, better contribution margins, better outcomes, all together in this study. Next slide, please.
Well, 1 second, it seems to not want to move.
No problem. No problem.
There we go.
Okay. This is one of our own studies, and this really looks at the effect of leakage and patients leaving. And again, we're going to focus back into the ER. And so this particular hospital system had been purchased, and it was a community hospital in a rural environment, and it's represented by that green line. And for years, the ER physicians had transferred patients to what was now a competitor, and that competitor is represented by the red line. And these are percentages. And so when you went and asked these ER physicians, well, why are you transferring patients to competitors? They had pretty good reasons. They said, number one, our high acuity area or ICU is a ghost town, particularly at night, and it puts the patients at risk when we put them there. It also puts us at risk when we put them there. They said, number two, when a patient boards in my ER and waits for a bed, I become the critical care physician, and I have to take care of them. And while I can do that, I also have to do things like set bones, deal with bee stings, all the things that an ER physician would have to deal with. And then number three, they said, it's just really easy to transfer patients to that red guy. You call them, they just tell you yes, and you're done. And so we did about three things with them. One, we wired their high acuity area so that they had 24/7 support. We streamlined a process where they could just hand the patients off to us seamlessly. Number two, we put telemedicine carts into the ER. And so if there was a patient boarding, they could hit a button on the side of the cart, and within about 30 seconds to a minute, one of the specialist physicians would be there to help take care of the patient. They would do everything from put in orders, write notes, talk to the family, talk to the patient, anything that a bedside physician would do short of a procedure. And then number three, we redesigned their transfer process to make it easier to use and more conducive to transferring within the system. And so what they found is if you track that green line, that over about a 3-year period, the percentage of patients going out of the system went from 29%, or staying in the system went from 29% to 72%. And the amount of patients going out of the system went from 60% down to about 20%. Now that was a net of 220 cases staying within the system annually. And that's now hardwired. And so, good change management expertise, but what it really is a triple win around patient flow. Good for the patients, good for the providers, and good for the hospital system. So win-win-win scenario. Next slide, please. One more financial study, and this was a survey of 20 rural hospital CEOs. Of these, half of them had been in hospitals that operated at a financial loss in the prior 3 years. 85% of them were critical access hospital CFOs. And so if you go to the next slide, there's some quotes for them. They're probably pretty instructive. So if I move to the very top left, I'll just read the quote. As a rural hospital, EICU has helped us to retain patients. Because we don't have 24/7 intensivist coverage in the ICU, with the EICU, we're able to retain patients and prevent from transferring them. The bottom left, I don't think any of us expected the virtual ICU to have the impact on volume on the inpatient side that it had. So I think that watching the financials change from that volume, I just didn't anticipate we'd ever go from 2 to 3 patients per day to full occupancy. And we were shooting for double digits. We were shooting for 10 to 12. And so, yeah, but I actually had to be convinced. If you move to the top right, it's a positive because I don't think we would be able to recruit and retain specialists here. To Eric's point, it's really hard to get the number of specialists that you need to run 24/7 if you're trying to recruit them to your local environment. But with telehealth, you don't have to do that. So next slide, please. I'm going to close here with 3 success stories. Thank you. One is a critical access hospital that was almost near bankruptcy. It was losing patients routinely, had a census of 0.8. They brought in a tele-ICU team or a telecritical care team, or really a tele-high acuity team. They put that service into the ER and then also on the inpatient side. Now, it was brought into the ER to prevent inappropriate transfers, to try to keep patients locally. And it was brought on the inpatient side to really rest their hospitalist team, make sure at night they were able to get sleep and they weren't getting burnt out. After about a 2-year period, the census rose from 0.8 to 3.9, and they plan on increasing further. So real financial benefit for the hospital, real benefit for the local patients, and then benefits for the staff. So again, that win-win-win scenario around patient flow. Next slide. Next one is a critical access hospital in rural Michigan. Hospital faced significant financial staffing shortages, and they brought in the telecritical care services, 1, to try to keep more patients, and number 2, to augment their ER team to make sure that they felt protected and had the ability to take these patients and really could rest easily. And so again, able to increase the number of patients that were staying and planning on adding multi-specialty services on after this, things like cardiology, nephrology, to really broaden the scope of services they can offer and really retain and keep patients in that community. And then next slide. A little bit bigger hospital, but again, in a rural area, a 200-bed hospital that during the pandemic had an ICU that was overwhelmed with COVID patients. And they had 2 or 3 member ICU team. That team, was working 24/7. They brought in a telehealth solution. Not only do they get things like Apache scoring and reducing risk-adjusted length of stay, ventilator days, and better best practices, but maybe more important for that community, their specialists can rest at night. Their burnout rates are lower, and they're able to really focus during the day on the patients and then go to bed at night knowing that there's someone there to help take care of the patients and can answer about 95% of their calls. So rested staff, better outcomes for patients, better data reporting, again, a win-win-win scenario. So next slide, please. So I think we'll pause here for questions, but when you're really working with telehealth, you need to do a couple of things. 1, planning and strategy is really important. Number 2, you really want to plan for and measure success. And then 3, buy-in's really important. Change management techniques are really important. And then after that, you just need to get started. No need for pilots, just jump right in. So I'll pause there and take questions.
Thank you so much, both Dr. Scurlock and Eric. We've got a couple questions that came in, and I'll continue to monitor those. So if you have more questions, please go ahead and put them in the panel now. To get us started, on the road to value-based care is better hospital operations. How does telehealth fit into those better operations?
I can just take a quick swing and then turn it over to the expert. Is again, as we talked about in the past, earlier on in the presentation, hospital operations are 85% fixed or step fixed costs, and this is just pure economics, right? Anything that we can do, you saw the number that Dr. Scurlock talked about, where they went from a market share of 29% to 70%, or just a huge uptick. That every single new patient allowed that hospital to become more efficient by diluting fixed costs over more units of service. And so I think it's a key ingredient to success is having the right volume to dilute fixed costs. And every rural hospital out there that I've come across in my 20 plus years of traveling around the country has an opportunity to capture incremental volume to become more efficient with that volume. Dr. Scurlock, how would you sum that up?
Yeah, at the clinical level, I think it's really around reducing, I think you're saying the same thing, reducing patient leakage, trying to capture the right patients to stay in that community. And to your point, once they stay there for that initial illness, they're also going to stay with you for life, hopefully. And if they leave, the same is true. They leave you for life. And so you really can build brand identity, operational effectiveness, really improve your improve your overall CMI. And then maybe most importantly, telehealth has very rich operational data. So you can get all kinds of metrics out of the telehealth program that you couldn't typically get with a face-to-face program.
Interesting.
Wonderful, thank you. Next question, what actionable strategies and best practices can rural hospital leaders implement to address financial and operational challenges, particularly in the context of telehealth integration?
I'll go first on that one, Eric.
Yeah, please do.
Right. Yeah. So often when you're designing telehealth programs, it's really important to bring in a couple of things. One are change management techniques. You really want to engage your staff, help them develop KPIs. You want to build a really strong guiding coalition when you're implementing this program. You want that coalition to come up with a vision of success. Once you have that vision of success, really over communicating it, and then picking an easy short-term win and hardwiring that into your system so the team builds credibility together. So that's really important to address those change management techniques. But it's also really important to get a proven partner. These are major capital outlays that you're going to make for a telehealth program, and you really want to de-risk it with a team that can help you and help you get it right the first time. Often your clinicians won't let you have a second chance if you don't get it right the first time, and so take all that risk out. Don't reinvent the book here, and just really focus on typical proven patterns of success.
Just to add a little bit of a different flavor to that. I look at where our rural hospitals are, right? The front doors of our hospital are the emergency room and the clinics. And if we could use telehealth, so I look at the inpatient unit. If we have a funnel, the bottom of the funnel is probably the inpatient unit. As we go up, you have the emergency room. If you go up in the funnel higher, you have the clinics and the specialty clinics and the primary care. And then you have your community, which is the largest part, often untapped. And so I think of kind of telehealth supporting kind of the bottom of the funnel in terms of being able to keep more patients on an inpatient basis. But as we move up, and then one of those front doors is having access to specialist physicians on a telehealth outpatient perspective, rather than to have them bring them into our community, is a great way of engaging our community in our specialist visits. And again, it's about having that volume to dilute fixed costs. I keep going back to that, but that's going to be the key to success here.
Yeah.
Wonderful. Thank you so much. So let's build on that a little bit. Who do I need to bring together across my leadership to discuss and plan out telehealth?
Great. I'll go first on that. Obviously, I think I said this earlier. So when you're building your telehealth program, think of the use case first, then build in the technology and your KPIs. So obviously you're going to need clinical leaders to help you define your use case and why are you bringing this strategic tool called telehealth in. So clinical leaders both and I'd have that multi-specialty. You want physician, nursing, pharmacy, whoever you have in your system that's going to be dealing with this type of patient. And then after that, you need to bring in technology leaders to make sure that is all working well. And so at the heart of any telehealth program, there are two things that have to be done really well. One is clinical process design, which is getting the clinicians together to address the change management issues I described, to describe how communication patterns will occur, to know where each person steps in and steps out in terms of the patient care. And those people need to meet before the telehealth program goes live, but they need to continue to meet after the telehealth program goes live, and their relationship's critical. And then in parallel to that, what you also need to do is technical process design. And the technical process design is getting the technology sides on both the telehealth vendor or the telehealth program and the hospital, and making sure that all the technical connections are there, testing the camera, making sure there's EMR access, making sure interfaces, if they're needed, are built. And that part needs to go in parallel to the clinical process design. That usually works much more efficiently and requires less meetings than the clinical part.
Okay. You've shared about staff buy-in to change, both to value-based care and telehealth. How do I make change attractive?
So I'll go back to those techniques I described before. We were real big believers in Cotter's techniques of change management, and those have been out for 30, 40 years now. And so they're not just true for healthcare; they're true for any industry. There's got to be a coalition of people involved. You got to get people from all sides to come together and really figure out what's the value of the program. Once you determine the value of the program, then you need to be able to articulate what success of that program looks like and really get it out to everybody in the hospital. It's often good to pick an easy, early, short-term win, because that short-term win can get you off on the right foot, get the program moving effectively, and then you pick harder and harder stuff. The more complex the telehealth program is, the easier I would make that short-term win, because there are things that are very discrete and there are things that are continuous over periods, and so you really want to pick that short-term win based on the difficulty of your program.
Can you have telehospitalists as your sole provider for inpatients in a critical access hospital? And does the H&P need to be done in person?
So I'll take that question too, unless you want it, Eric.
Oh, no.
Okay.
Stay away from H&P.
Yeah. So you'll need someone in your hospital who can do procedures and can be available for codes and those types of things. That can be an ER physician, an APP. It can be a non-hospitalist if there's there, but there needs to be someone with boots on the ground to help intervene in those emergencies or procedural-based issues. And often that's the same person as you had before the telehealth program existed. You don't need to bring in somebody new, because with telehealth, you're not taking things away, you're adding to. In terms of the H&P, that can be done either, particularly in critical access hospitals, that can be done either remotely or face-to-face.
Great, thank you. Another question that came in: as a referring hospital to a larger network, what are the views of such organizations to telehealth within the smaller hospitals?
I'll go. So it's really I think the larger hospitals look at the smaller hospitals, and there's really two things. And I'm going to go back to this concept of patient flow, but maybe look at it from the other side and how they view it. So they want the highest acuity patients that they can possibly get coming to their hospital, and they want the lower acuity patients to stay out in the periphery typically. One, because it helps prevent congestion at the bigger hospitals, but number two, it helps regulate case mix index, and it's also, number three, and most importantly, it's the right thing for the patients. And so often larger hospitals will have telehealth programs that help keep patients local, but also try to identify patients that maybe need higher levels of care and bring them into their environment. So hopefully they're looking at a way to provide access while also looking out for the financial viability of both systems.
Great. All right, so we just have a couple minutes left, so I'll ask this final question. Efficient operations also includes my staffing needs. Can you share your thoughts on workforce in rural care and VBC telehealth?
Go ahead, Doc.
Okay, you got it. So let's just talk workforce and the way it's moving. And there are significant challenges with the workforce. And so the one that's really easy to explain and the one that's really easy to remember the numbers, but this is true of all the specialties. So psychiatry, let's think about psychiatry. 50% of US counties do not have a psychiatrist. 50% of psychiatrists are 60 or over. Now, those numbers aren't markedly different for certain specialists. And surprisingly, one of the specialties that will be the shortage in the next 10 years is cardiology. So critical care, cardiology, pulmonary, infectious disease, nephrology, there's always going to be massive shortages over the next 10 years. In addition to the shortages, there'll be geographic maldistribution. And what I mean by that is there'll be clusters of these professionals in cities where there maybe are too many of them, and there won't be any in rural areas. And so telehealth is really one of the few ways to obviate that. And as long as it's set up the correct way, in ways that can help the smaller hospitals, but also help patients and identify patients for the bigger hospitals, that's really a win-win scenario across the whole spectrum.
Great. Thank you so much. I will end our Q&A now and turn this back over to your closing remarks. Thank you for everything and answering the questions. I know our audience very much appreciates it.
Eric, Kodi,
look forward to seeing many of you in Kansas City in a couple of weeks. So
Absolutely.
thanks everyone for listening in, and you know, our goal is to have you guys get something out of it. So Corey.
Yeah, I was going to say thank you to Kodi and thank you, Eric, for being up here, and you know, looking forward to meeting everybody again in Kansas City as well. So thank you for the opportunity.
Absolutely. And thank you everyone for joining us today. As both Eric and Dr. Scurlock have said, I look forward to seeing you all in Kansas City in just under 2 weeks. Very excited to be there. I hope you found this webinar informative and engaging today. As a reminder, a recording will be sent to you later today. But before you leave, please take a moment to answer the short survey at the end of the webinar. Your insights guide us in providing even more valuable content to you in any future webinars. So again, thank you and have a great day. We look forward to seeing you in Kansas City.